Well, welcome everyone to the EKG case for the week of September 2nd, 2013. This is a bit of a continuation from last week's case where we were talking about wide complex tachycardias and trying to distinguish between SVT with bundle versus ventricular tachycardia. And just to skip to the chase of what we discussed last week, it was my opinion to simply say that we don't have any good reliable criteria that rule out VTAC and leave you by default with the diagnosis of supraventricular tachycardia. The Brugada algorithm, the Griffith algorithm, and all the rest of those algorithms fail miserably when they're tested. On the order of 10 to 15% of cases of VTAC will be missed when you use those criteria. So I proposed a very simple, a little bit facetious, but Mattu algorithm, which is the most simple-minded approach to wide complex tachycardias, which fits what my brain is capable of doing. 2 steps. Question number 1, does the patient clearly have sinus tach? And if it's not clearly sinus tach, move on to step number 2, which quite simply is, it's a ventricular tachycardia. You're done. It's very easy. And the benefits of having this simple-minded approach are threefold. Number 1, there's less stress to you because you don't have to spend your time trying to sort through those complicated algorithms. Number 2, you will save lives by following this simple algorithm. And number 3, perhaps most importantly, it saves you brain space. There's more room left in your brain for really useful things. For example, remembering your wife's birth date or your kid's birth date or your anniversary date or something useful, something that will be productive and actually save lives. For example, this. Okay, so I also mentioned last week that we would talk a little bit about adenosine because a lot of people have turned to adenosine as a diagnostic challenge when they have a wide complex tachycardia and they're trying to distinguish between SVT and aberrant conduction. So let's talk about that. But before we do, I want to pose a very simple question for you. All right, here it is. Have you ever taken care of a patient with chest pain and thought deep down in your heart, there really is not much chance, maybe a 3 or 4 or 5% chance that this patient's having acute coronary syndrome, but I think I'm going to admit this patient anyway. In other words, even though you kind of thought it was probably a benign diagnosis, you went ahead and you admitted the patient anyway for the full-blown workup. And related to that, what percentage of patients with a potentially deadly condition, for example, ACS, what percentage of patients with potential ACS would you be willing to misdiagnose as having a benign condition and send them out? Would you be willing to miss 3, 4, 5%, 10% of your patients with ACS? Or is it, you don't have much tolerance for missing any of them? Maybe a 0.5%. What exactly is your threshold for misdiagnosing patients and with the deadly condition and calling them a benign condition? And with that in mind, what percentage of patients with ventricular tachycardia would you be willing to misdiagnose as having supraventricular tachycardia and sending out? All right, so it's a very relevant question. VTAC is a deadly condition. Are you willing to misdiagnose VTAC and call it SVT? And if your answer is yes, what percentage? 5%? 10%? Give it some thought. Hit the pause button and come up with a number. Because if you're not willing to come up with a number, there's no point in even listening to anything more I have to say. In fact, you might as well just drop out of emergency medicine and go and practice, I don't know, podiatry or something else like that. Not to say there's anything wrong with taking care of the feet, but stay away from the heart if you can't answer that question. Okay, so let's talk about a case. This was sent by Dr. Allison Suarez, who is an emergency physician, academic teacher up in New York at one of the residency programs up there. Allison is, dare I say, an EKG nerd herself, a fellow EKG nerd. She loves teaching EKGs up in that program and has sent me some great cases. This is one of my favorite cases that she sent me probably a few years ago, but I pulled it out for this. This was an 84-year-old man that her colleagues were taking care of who presented with some palpitations. All right, so wide complex tachycardia, obviously, and the patient was relatively stable. So the patient was given some adenosine, and what do you know? The patient converted to sinus rhythm. Adenosine convert. So that means this clearly is SVT, right? Well, she knew it wasn't SVT. In fact, if you go back to the original 12-lead EKG, this is clearly ventricular tachycardia. All right, forget the Mattu algorithm. If you go back through any other algorithms, you come up with VTAC also. The patient has a taller left rabbit ear. The patient has axis in no man's land, extreme right axis deviation. There's also a much deeper S wave in V6. There's 3 really good reasons that this has to be VTAC. Well, cardiology came, saw the patient, said, yes, it's clearly VTAC. This is one of those examples of adenosine sensitive VTAC. What are you talking about? Some of you may be saying, adenosine sensitive VTAC. I've never heard of such a thing. Well, now you have. And it turns out that the electrophysiology community has known about this concept of adenosine-sensitive ventricular tachycardia for a long, long time, but most people don't know about that. And so there's this myth that adenosine can reliably tell the difference between VTAC and SVT with aberrant conduction or bundle branch block, essentially. And the truth is that, well, we know adenosine doesn't always work for SVT, but adenosine will convert some patients that have ventricular tachycardia. And again, most people don't know that. Emergency physicians, internists, general cardiologists, invasive cardiologists, most people don't know about that, but the electrophysiologists do. In fact, it's written all over the electrophysiology literature, and the literature indicates that up to 5 to 10% of cases of VTAC are actually adenosine sensitive. In other words, they have proven VTAC, and you give them adenosine, and they will convert back to sinus rhythm. Making things even more difficult, the literature says that most of these are fairly young patients with no underlying cardiac abnormalities or cardiomegaly or atherosclerotic lesions. They have no underlying coronary disease in their young patients. These are the very patients we would most want to assume have VTAC. There's a couple of studies that I pulled in here, both from Japanese journals, and there's nothing relevant. There's nothing that makes this more specific to a Japanese population. It just so happened that a couple of quick lit searches pulled up these articles. Here's an article in which 5 out of 10 consecutive adult patients converted with adenosine. Here's a pediatric patient. Pediatric VTAC does occur, and a lot of them convert with adenosine, and yet this is still a deadly type of ventricular tachycardia. Let me show you a couple of more cases. This was a patient. Now, bear in mind what happens here. All right, this is a 54-year-old man who came in with palpitations and stable blood pressure. He went to his doctor's office and was noted to be tachycardic, so his doctor said, go ahead and drive yourself to the ED. Don't you love that? Thankfully, he didn't crash. But anyway, he arrives in the emergency department, and he's got a wide complex regular tachycardia. And in fact, this is definitely ventricular tachycardia. How do you know? Well, these red arrows are pointing out evidence of AV dissociation. See those little P waves right there? There's AV dissociation. That's definitely VTAC. What else? He's got a taller left rabbit ear. What else? He's got a deeper S wave in V6. What else? He's got right axis deviation. What else? He's got a fusion beat. He's got 4 or 5 different reasons to definitely call this VTAC, but he had a stable blood pressure, and he was just chilling, saying, yeah, my heart is beating kind of fast. He's 54, relatively young, right? He's got no history of cardiac disease known, and because he had a stable blood pressure, they thought, well, this must be SVT. A general cardiologist came to see this guy in the ED and said, stable blood pressure, no risk factors, go ahead and give him some adenosine. So he gets some adenosine, and he ends up converting to sinus rhythm. Now, this is something that was missed. He actually does have continued AV dissociation. That was missed, but this was judged to be supraventricular tachycardia right here because he converted with adenosine. So what ended up happening? Well, there was some argument about whether he even needed to be admitted, right? Why would you admit an SVT that converts? But nevertheless, they admitted him to the hospital, and the night of his admission, he went back into VTAC, except this time, he decompensated into ventricular fibrillation. So a code got called, ran up, took care of the patient. The cardiology fellow came down and took care of him. The senior medicine resident and an emergency medicine off-service intern who was rotating through one of the inpatient services. The 3 people went to see him. They ran a code. They got the guy back. He He was up on the telemetry floor, and they're writing orders for him to go up to the CCU now on a lidocaine, at the time, lidocaine drip. Well, right around then, it's around 6 o'clock in the morning, the cardiology attending who's covering the CCU comes walking in and says, "Hey guys, what's going on?" So the cardiology fellow looks at the attending and says, "Well, this 54-year-old guy got admitted last night from the emergency department with SVT. He got adenosine, he converted, but last night he coded, and so we ran a code and sent him up, and we're sending him up to the unit now." The electrophysiologist looks at the 12-lead EKG that brought him into the hospital and said, "Why in the world did anybody think that this guy had SVT? He's got AV dissociation, fusion beats, right axis deviation, taller left rabbit ear, deep S wave in V6. This is definitely VTAC." The cardiology fellow looks at the senior medicine resident, who looks at the EM intern, who looks back at the cardiology fellow, who finally responds and says, "Well, he converted with adenosine, so he was diagnosed with SVT." The electrophysiologist threw his hands up in the air and said, "Everybody knows VTAC responds to adenosine. This is malpractice. He should have been admitted last night to the CCU on a lidocaine drip, being prepped for an EP study today. He should never have been on the telemetry floor." And then this guy just stormed off as if everybody in the world knew exactly what he was talking about. And this cardiology fellow happened to be an ACLS instructor and had taken ACLS a couple of times, and the senior medicine resident had taken ACLS one or two times, and the emergency medicine intern, who was me, had taken ACLS. None of us had ever heard of this ever before, and yet this electrophysiologist figured everybody knew about it. So after that incident, I went and I did a lit search, and sure enough, ACLS was wrong. Adenosine is not a good way to distinguish between VTAC and SVT. It's all over the EP literature. If you go and do a quick literature search, you will find articles detailing this adenosine-sensitive VTAC everywhere, but primarily in the electrophysiology literature, not in the general medicine or internal medicine or EM literature. Here's another case. 74-year-old guy with shortness of breath, stable blood pressure, history of CHF. Look, he's got CHF. He's 74. He's got shortness of breath. Who cares that he's got stable blood pressure? You know what? When you see a wide complex tachycardia with all these risk factors, don't even look at the 12-lead. Just call it VTAC. Remember the Mattu algorithm. Unfortunately, because he had a stable blood pressure, the physician said, well, maybe it's SVT, so let's give him some adenosine. And he gets adenosine and sure enough converts right to sinus rhythm. He gets admitted to telemetry and coded that night with a very similar outcome to the previous case when he went back into VTAC. So these adenosine-sensitive VTACs are not always stable, but they can mislead you into treating them like SVT. Look, this guy's got something called a steeple sign, which is when the QRS goes straight up and straight down. There's no rabbit ears. That is enormously specific for VTAC. He's also got maybe some very subtle AV dissociation in there, and he's also got a QRS that's greater than 160 milliseconds. All of these are very specific for VTAC. This is VTAC, but he converted with adenosine. That was later proven in an EP lab, and this guy walked out of the hospital, fortunately, with an AICD in after his EP study. All right. So bottom line is adenosine is not a reliable way of distinguishing between these two. Now, here's a quote from out of ACLS 2010. Recent evidence suggests that IV adenosine is relatively safe for both treatment and diagnosis. Class 2B, level of evidence B, which stands for bad, as far as I'm concerned, right? Well, what is the evidence upon which they stuck this back in the guidelines and said you can use adenosine to help diagnose VTAC? Here's the study that got it back in ACLS 2010, because it had fallen out for a while, and then in 2010 they put it back in. This is the study. Merrill looked at adenosine for wide complex tachycardia, and the main thing they were looking at was actually not the efficacy but the safety. They wanted to find out if adenosine is safe, and sure enough, what they found was that adenosine was safe. It really doesn't cause decompensation. Yeah, there's case reports out there of adenosine causing problems, but for the most part, let's just agree that adenosine is safe. But they also looked at how effective it was at converting. And in the study, what they ended up saying was that adenosine only converted 2 out of 81 VTAC patients. So that's clearly less than the 5 or 10%. And so a lot of people assumed, adenosine really doesn't often convert VTAC. So go ahead and use it as a diagnostic challenge. But here's the major problem with this study. They used conversion with adenosine to diagnose SVT. 48% of the patients that they diagnosed with SVT, they diagnosed with SVT because they converted with adenosine. How silly is that? How can you say that adenosine doesn't convert VTAC when in fact you're saying that it must be SVT because it converted with adenosine? That's ridiculous. So what it means to me is that whoever wrote this section of ACLS ought to be flogged because they didn't read the study. They just stuck this recommendation back in without reading the study. If they had read the study, half the patients that were diagnosed with SVT were diagnosed because they converted with adenosine, and then they come back and say, oh, it only works in 2 out of 81 cases of VTAC. That's crazy. So be very careful. The bottom line is, yeah, adenosine is safe for using in wide complex tachycardias, but it does not rule out VTAC. It doesn't reliably distinguish between SVT and ventricular tachycardia. Now, some people will say, well, what's the difference? Why not just give adenosine to all of these patients? And if they convert, well, you've solved their VTAC anyway. Who cares? Well, there's a big problem here. All right, what do you normally do with SVT? Well, you send them home, right? Or even if you admit them, they get a rapid rule out, then they go home. There's not a lot that you do for SVT. But if somebody's got VTAC, the management's very different, right? They go to the CCU, they get put on a drip, they get ruled out. Oftentimes they go for a cath. Invariably, they go for an EP study, and they may possibly end up getting an AICD. So if you misdiagnose somebody as having an SVT, and they actually have VTAC, well, maybe their treatment was safe, but their inpatient management is very, very short-handed. They didn't get the full workup for VTAC, and they may have a bad outcome down the road. The management of SVT versus VTAC is very different, so when you misdiagnose these patients, even if they survive that management, their outcome can be very, very different. So that's a big deal. The bottom line is that the response to adenosine does not rule out ventricular tachycardia. So I go back to the initial question, what percentage of patients with VTAC are you willing to misdiagnose as SVT? Now, this is an important question. I'm not telling you that you absolutely cannot use adenosine for VTAC. It is safe, but you have to remember that if you give adenosine to the patient and they convert, that does not mean that you've just diagnosed SVT. They still need to be closely evaluated for the possibility of VTAC, because in 5 to 10% of those patients that convert with adenosine, you may still be looking at ventricular tachycardia. And the last thing you want is to end up assuming it's SVT and treating them like an SVT, sending them home, and skipping what really should be an appropriate ventricular tachycardia workup. So be very, very careful about making any conclusions just because somebody converts with adenosine. Now, back at ACEP this past year, there was a cardiology panel and a group of physicians that got together, and they talked about this concept, and they kind of downplayed the whole concept of adenosine-sensitive VTAC. They said, I'm not going to worry about it. Only 5, maybe 10% of patients have adenosine-sensitive VTAC. And so why bother worrying about it? Well, once again, let me ask you this. What percentage of patients with the deadly condition are you willing to misdiagnose? I don't think you should be willing to misdiagnose 5 or 10% of your patients. So again, I will say it again. Be very careful about using adenosine as a diagnostic maneuver, because 5 or 10% of your VTAC patients will convert with adenosine. Take a look at the EP literature. And, well, don't make any conclusions just because they convert. Those patients still need a really, really thorough workup and scrutiny of that EKG, and maybe all the way through the EP test. All right. So I hope that clears up some myths. I'm sure that's a bit controversial to some people out there, but again, play it safe. I'm not telling you to do anything crazy. I'm just telling you to shock people more often. Well, maybe that didn't come out right, but I'm telling you to be conservative and assume it's VTAC and treat them as VTAC And in my opinion, adenosine is not part of the normal management of VTAC. It's kind of like giving Maalox to your ACS patients. Be careful. Hope that was helpful, and I will talk to you next week. Bye for now.